So it's my absolute pleasure today to introduce Mr. Daniel Walsh. So Mr. Daniel Walsh is a consultant neurosurgeon specialising in vascular neurosurgery and brain and spinal diseases. He trained at leading UK institutions and completed a fellowship in cerebral vascular surgery in Sydney, Australia. He is the South Thames Training Programme Director in Neurosurgery, a member of the National Neurosurgical Selection Panel, and serves on the EANS Committee. And he's going to talk to us today about Cavernoma 101, understanding your diagnosis. And I'd just add as well, Mr. Walsh, we're very grateful for the fact that you're coming back again. You've done several talks with us, so we're very, very grateful for that. So Daniel, I'm going to pop the spotlight on you now, and then if you would like to screen share, that would be amazing.
Okay, good morning, everybody. If you could give me some feedback as to whether A, you can see the slide, and secondly, you can actually hear me, that would be great.
So Daniel, I can confirm it seems awful, isn't it? You never know, but I'm pleased to confirm we can hear you, we can see you nice and clearly, and I'll stay on before you start just to confirm that your slides are sharing okay.
Okay, so good morning, everybody. Thanks very much for the opportunity to share this Saturday morning with you. I've been asked to talk about Cavernoma 101. So I prepared this talk from the perspective of perhaps meeting somebody with cavernoma for the first time in my clinic, and it reflects a lot of the questions that I get asked. You may well wonder what my qualification to give this talk is. I'm a neurosurgeon. I deal specifically with neurovascular disease of various sorts, including cavernoma. So to begin with, I should explain to you I do not have any pecuniary conflicts of interest to declare to you related to cavernoma treatment. Apart from the fact that I do have a private practice as well as an NHS practice. The other thing I just wish you to be aware of is that I may occasionally use images of anatomy, surgery, and such things. Being a surgeon myself, I think they're beautiful, but you may not. In which case you might wish to continue in audio, but I don't think there's anything too distressing. So a good way to start a talk like this is to tell a story, isn't it? And I'm going to tell you a story from a few years ago in that aforementioned private clinic. It's one of the things about being a cerebrovascular surgeon is it's not a terrific business model. I should have been a plastic surgeon or an orthopedic surgeon or something where there's a high demand for lots of procedures by lots of people all the time. And cerebrovascular surgery, we're very often talking to folks about conditions that have the potential to harm you, but have not yet, and maybe they never will. So sometimes adopting a more expectant approach rather than leaping straight in can be the right way to go. So imagine my delight in the first week of January many years ago when my waiting room was packed out for several weeks in the wake of Christmas. I thought, my gosh, I'm a success. Whatever am I doing right? And unfortunately, it was short-lived because do you know what had happened? Over the Christmas holiday, some entrepreneurial type had the brilliant idea that people would like a picture of their brain to hang on their wall. So they constructed a well-known type of gift voucher and marketed these vouchers independent of any medical input as a Christmas present, as a sort of experience. So you would go, you would have your MRI, and then you would print off a picture of your brain to hang up as a talking piece in your living room. The unexpected consequence for this entrepreneur was that these scans inevitably got reported by a radiologist along the way, and they started to get advice that lesions had been identified, benign brain tumors, vascular malformations, aneurysms, and cavernomas. as is the case in about 1 in 300 MRIs that are done in healthy asymptomatic people. So these folks ended up with an additional Christmas present that they did not enjoy, which was the advice to go and talk to somebody like me. And that is how many people find out about their cavernoma these days, as high quality imaging of the brain has proliferated. If you get hay fever these days, somebody might want to do an MRI on you. So we're much more likely to trip across asymptomatic lesions in the brain than we ever have been before. In fact, it now accounts for a little over half of all the cavernomas coming to medical attention. But perhaps only about 1 in 2,000 cavernomas will actually cause symptoms, despite perhaps 1 in 500 of us harboring one.
And Daniel, sorry to interrupt, just to check, are you sharing slides at this point? Because if so, we can't see them, but I wasn't sure if you were
Right.
sharing slides or not after the anecdote.
No, there were 3 slides.
Ah, I'm glad I intervened just to check then. Could you try sharing again? And so sorry to stop the flow. I was enjoying that anecdote so much and thinking, oh my gosh, they often.
There was a visual gag in there too.
Oh no, we missed out on that
So
punchline. I should have, I was just like listening and thinking, that's extraordinary that they would have offered that without thinking about the the medical consequences. And sorry to put you on the spot. It's awful, isn't it, when you're trying to talk and then do technology at the same time. Fantastic. It's now sharing. So if you just want to go to the slideshow, that'd be amazing. And apologies, I should have twigged a little sooner that you might have a picture to illustrate with that story. Thank you, Daniel. We can see this now nice and clearly. So I'm going to hand back to you.
okay. So that was my waiting room just after Christmas. And as you can see, a lot of people with very unwelcome presents. So I think we'd gotten to the point where I was explaining that about 1 in 500 of us might harbor a cavernoma without realizing it or without it causing any symptoms. And it might never cause symptoms. About 1 in 2,000 of those that are identified do seem to cause symptoms. And a proportion, perhaps about a fifth of all the cavernomas that are identified, can be traced to inherited disease, with multiple generations of a family having experience of the condition. Genetics plays a role in the development of any type of cavernoma. The familial cavernomas are characterized by something called germline gene alterations. And genetics for all of us, including surgeons, gets sort of complicated and difficult to focus on. So the way I like to think about this is you think of your genes as your body's software. When there's a germline alteration, the original software, version 1.0 that came with the computer, has been affected. And every cell in the body, including the cells that are involved in reproduction, have copies of these altered genes. But there's another kind of alteration that can happen. And I sometimes think of this as a version update that you download from your computer supplier of choice. And then you discover there's a problem with the update and the code. And these are somatic mutations. These are not found in cells involved in reproduction. They're not typically found in every cell of the body. They are generally found only in the pathology they're linked to. These two entities, somatic and germline mutations, can cooperate and probably need to cooperate to produce disease. So if one takes the example of familial cavernoma, think of many cells having multiple gene alterations, creating the potential for cavernoma to develop in multiple locations within the nervous system. That activation of that potential sometimes resides in a somatic alteration. Why would a gene change during life? Well, it may be because of some factor in a person's environment, and I'll show you an example of how that can work in a moment. But it's usually necessary both for these germline mutations to cooperate with a somatic mutation, first to create the cavernoma in the first place, but later for it to become a problem, to start leaking blood or growing or cause interfacing with the tissue around it to cause disease like seizures. In sporadic cavernomas, which account for most of us, it's necessary for more than one somatic mutation to develop in most of the pathways we understand, although there is one pathway, MAP3K3, where a change in a gene that allows it to acquire an additional function it was not designed in creates the possibility for cavernoma to develop, and that possibility is then realized by another somatic mutation later on in the environment. So the long and the short of that is your body's software is playing a role in the development of cavernoma, whether that cavernoma is inherited from your parents or not. And it's also quite likely that we don't understand exactly all the code that's involved in that process. So although we give names to certain genes and the pathways they affect and the proteins that downstream they produce, at the moment, there may be other pathways and other genes operating singly or cooperating with the ones we know to produce the condition. Now, a good example of how an environmental factor can affect genes to produce disease is ionizing radiation. And in fact, it's been known for some time that if you were unlucky enough to need radiotherapy to your brain early in your life, that was associated with an increased risk of developing cavernoma later. This is an example of a series of children treated for various cancer types, surviving but having therefore ongoing MRI surveillance for many, many years, enabling the detection of cavernomas when they developed. And about 10% of those children were found to develop cavernomas, although some of those developed as long as 24 years after the original treatment. So that's an example of an environmental stimulus influencing the way genes work and maybe turning on those somatic gene alterations to produce the disease. The interest in this really is about identifying potential therapeutic targets. If we understand sufficiently how these genes are turned on and off and produce the disease, it raises the possibility that in the future we develop treatments targeting those genes to switch them back on or back off again as appropriate and mitigate the disease, even if it's not to get rid of the cavernomas per se, but maybe to make them less likely to grow and less likely to leak blood. So, what precisely is a cavernoma? There's a distinct possibility when you first meet your doctor that they will mention fruit. Cavernomas are thought to or said to resemble mulberries or blueberries, depending on what part of the world you're from. And there's a picture of some berries by the side of the road on a walk in Ireland some years ago. The MRI appearance of a cavernoma hopefully mirrors that. What the berries are showing. Imagine these caverns containing juice in the berry are in fact these caverns within an MRI, so an MRI image of the cavernoma as seen here. The way an MRI works is it assembles information about how much water there is in different tissues of your body. And then we can manipulate that information to emphasize things we're interested in. So a cavernoma on an MRI, this is a T1 MRI sequence, but the cavernoma spaces that contain blood are relatively bright, indicating a more liquid component. Around the margin, there's a dark halo. And what that actually is iron, which is an element of the hemoglobin molecule, the oxygen carrying molecule in your blood. And that iron leaches out, staining the brain around the cavernoma. gets wrapped in a protein for safety because iron is quite toxic to the brain. And therefore the body wants to protect the nerve cells from it. The protein's called hemosiderin, and it's that which creates that characteristic dark halo one will often see around a cavernoma on an MRI. Surgery image alert. This is a picture of somebody with a brainstem cavernoma having an operation with me. And hopefully you see from that the fruit analogy stands up quite well. There's a space around the cavernoma that you see, which has been created by liquid blood that I've removed. The tissues around this collection of berries is a sort of golden color. In reality, that should be lily white. The reason it is that golden color is because it has been stained by iron. So on an MRI, all of this tissue will appear dark, black, whereas the caverns are these liquid-containing bubbles at the center. The cavernoma is connected to your circulation by very, very tiny blood vessels. So blood enters it under very, very low pressure. These are not tense, throbbing entities. They're quite soft and compressible, and they'll pop with very little manipulation, allowing the liquid blood to leach out. So this is what they look like if you take those berries and you slice them very, very thinly and wash the tissue in dyes that cells pick up. If you didn't dye the cells just look like translucent film, and you can't see the organs within the cells. But each of these areas here, and I hope you can see my cursor, is a cavern. The dark red dots are red blood cells contained within the cavern, and the cavern is a single layer of cells called endothelia. The blue dots within the light pink endothelial cells are the endothelial cell nuclei, the control center of the cell, stained up. And there's a single layer of these cells that runs around the cavern containing the red blood cells. When these cells are functioning normally, as they would in your normal blood vessels, they form the inner lining of arteries, for example. So they are the thing that is in contact with the flowing blood going by. They are stitched together very tightly by proteins. An example here taken from the Cavernoma Alliance website is adherin. And proteins like this encourage the cells to stick together very tightly, keeping a barrier between the fluids within the substance of the brain itself and the flowing blood. But their activation of some of those genes changes the protein makeup within the cell such that those proteins don't necessarily link up, creating gaps that allows blood to leach between the cells and out into the brain tissue. Now, a very common question I'll be asked at that first consult is it a brain tumor? And while the short answer is no, it's maybe worth saying that the term tumor just means lump. It doesn't necessarily indicate cancer, which is usually what we're asking. The dictionary definition is of a swelling of a part of the body, generally without inflammation, caused by abnormal growth of tissue, whether that tissue is benign or malignant. So you might argue it meets some of the criteria for a mass lesion. But in fact, most cavernomas, even when they're large, because they're soft, compressible structures, don't produce symptoms very often by direct pressure on the brain in the same way something like a benign brain tumor would. So, no, in the sense that you're asking, it's not a brain tumor. It's a thoroughly benign entity made up of cells that had ambitions of being normal blood vessels, but for whatever reason, don't quite become that. Another question that crops up, particularly if somebody has access to the internet is they see cavernomas referred to as vascular malformation. And there's a whole family of diseases made up of maldeveloped blood vessels. Um, these can broadly be broken down into two groups. There are those where the blood flows directly from high pressure hoses, the arteries in blood, into veins, creating a short circuit. And then those veins are under very high pressure, very high tension. Those are called arteriovenous malformations or shunts. Cavernomas are not characterized by blood flowing directly from arteries into veins. If one is in doubt, one can do a test called an angiogram, and this angiogram is being carried out on somebody with something called an arteriovenous malformation. On the left here, blood's flowing into normal arteries, but pretty quickly I can tell you those look rather bigger than usual. And as the blood makes its way through, it finds its way through a tangle of abnormal blood vessels here and starts to flow directly out through very enlarged veins. That short circuit into the veins is not seen on cavernomas. In general, cavernomas are invisible on an angiogram, but just occasionally they will be associated with something called a developmental venous anomaly, or DVA for short. This is an angiogram showing a DVA, and a DVA has a very characteristic appearance, a little bit like a hydra or a sea anemone. And the blood flows from artery to vein. But as you can see, by the time it's getting out the vein, the arteries have disappeared. So there's no short circuit. So cavernoma does not alter that relationship between blood flowing through the artery and coming back out the vein. The next concern for most of us, if we're reading around this disease, is that it might cause some form of injury to our brain or our nervous system, specifically something called a stroke. And I've talked about this before in a webinar for you. The term stroke is a collective term. It's an umbrella term for anything that physically destroys nerve cells. It goes way, way back to, the time of ancient physicians like Hippocrates seen here, who gives a very detailed description of what is surely a hemorrhagic stroke. As you see there, suddenly a healthy person seized by head pain. Immediately the voice fails, the mouth opens, he groans, nothing with meaning. This is probably a left hemisphere brain hemorrhage affecting that person's speech area. And he notes as well how frequently it was fatal in those times. For many hundreds of years, that was the extent of our understanding until we reached Galen, who was about 400 or 500 years later and practicing in Rome, although born in Turkey, modern day Turkey. And he began to recognize that you could locate where in the nervous system a problem was developing from the pattern of the symptoms described by Hippocrates there. So the modern definition of stroke broadly breaks it into two groups. You have strokes where cells die because arteries become blocked, or you have strokes that occur because the arteries leak and the physical injury of the blood expressed into the substance of the brain is what creates the symptoms and the disability. And this is typically the type of stroke that cavernomas will produce if they bleed. But we in our profession have been historically very, very inconsistent in what we term bleeding. And it's probably useful to distinguish between certain subtypes of bleeding. It is in the nature of cavernomas to leach small amounts of blood into the tissues around them, as we've already seen. They're leaky. Now, is that quite the same thing as overt bleeding that causes symptoms straight away? When we want to know, has there been fresh bleeding, this test that's often most useful is a CT scan, which is seen here on the left. We're looking at a slice through someone's head. We're looking up from their feet. So over here is the left, over here is the right, This is the forehead. You can just see the ears on the side of the head there. And a CT scan is a type of X-ray. The X-rays pass through the body and they are affected by how dense the tissue they're passing through is. Blood is initially very dense when it's a clot. So if there's a blood clot there, it shows up as bright white. Now, there is an abnormality in this area of the brain here with a small spot of white within it. That could be a small amount of fresh blood. It could be a small bit of calcium, similar density to the bone of the skull that you see around it. But what there is not is a large amount of blood in the brain in this area. An MRI on the same patient shows the abnormality far more clearly, and we can appreciate the characteristic appearance of the caverns at the center, which contain liquid blood, surrounded by the hemosiderin protein protecting iron from the brain. But this, if there is any bleeding at all, is contained within the cavernoma itself. It is possible for there to be a sudden release of blood that is capable of producing symptoms, a seizure because of sudden swelling, a severe headache, yet be contained within the cavernoma itself. And we call that intralesional bleeding, an example of which I've taken here. You can see there's even a little fluid meniscus within the cavern here. And on the MRI, we can appreciate that the sudden change in pressure within the cavern has created this white signal on the MRI around the cavern, which may be enough to precipitate a seizure or produce a focal deficit, but without physically destroying the brain nearby. That can go down again and recover. So the outlook for an intralesional bleed, sometimes we talk about things like microhemorrhages, which are probably small intralesional bleeds. And if they're in very eloquent locations within the brain, it's very easy for small amounts of blood, small changes in the volume of the cavernoma to produce a symptom. It is probably useful to distinguish that kind of bleeding from this kind of bleeding, where we get extralesional bleeding. And in this case, a very large cavernoma here is associated with a very large blood clot that has grown out from it, intruded into the surrounding brain. Can you appreciate that it's pushing the brain across to the other side? So great is the pressure. And the white signal that you see on the MRI now reflects swelling, inflammation in the tissues around it as well. But there is physical injury to an element of the brain tissue here associated with this. And undoubtedly, this requires emergency surgery to remove that swelling and hopefully prevent any further injury to the still viable brain nearby. The next most common presentation of a symptomatic cavernoma is probably seizures. And a seizure is a usually temporary electrical discharge that will interfere with your brain's function. We are all just electrochemical computers, and any one of us could potentially have a seizure in the right environment. Our nerve cells in our brain are creating little electrical currents by allowing chemicals to flow in and flow out of the cells. And those electrical messages are precipitated all over our body. But say we get a very high temperature, that can alter the electrochemical balance in a way that could produce a seizure. Febrile convulsions in children with high temperatures being a case in point. When we talk about a provoked seizure, it is because some event has created that circumstance. For example, hemorrhage from a cavernoma can provoke a seizure. When that becomes a recurring event because of established injury to the brain, then we begin to talk about epilepsy, epileptic seizures. Seizures can be thought of as well. You'll sometimes hear them described as simple and complex, which is very confusing terminology because it's not a qualitative judgment about the seizure. Simple means that the person retains their consciousness during the seizure, whereas a complex seizure, you lose consciousness. Another way of dividing them up is into focal seizures. So simple seizures might well be focal. You may notice twitching in a limb in isolation. Whereas generalization is when that twitching comes to affect the rest of the body and may, we call it secondary generalization if it spreads. It's thought to be about a 6% risk per annum if you're living with a cavernoma that you might suffer a seizure. But bear in mind, there are other reasons people have seizures too. Head injuries, as I said, the right environmental situation, including alcohol, high temperatures, a great many things, and sometimes endocrine disturbances in the body. Another very common symptom is headache, and we've seen examples of that would be easy to understand why a headache was produced when you see a big blood clot, like in that earlier slide, pressing on the brain. But most headaches reported in association with cavernomas are probably not for that reason. And many of them overlap with other common and benign headache types that are frequently seen in every GP surgery around the country. A particular subset of headaches is migraine, and migraine has been increasingly of interest to people who are interested in blood vessel problems, because it is more and more understood as a disorder of a central regulatory network that controls the diameter of blood vessels and hence the amount of blood flow through them, not only in the brain itself, but in the lining of the brain, in the nerves that emerge from the brain that provide sensation to the face and scalp. And that understanding has created new potential therapies for really difficult to manage migraine. Professor Peter Goldsby at King's and his team have worked on a thing called calcitonin gene-related protein inhibition, of which has proved to be very effective for people who've had untreatable migraine for years. But one person did have a brain hemorrhage during the initial trial of that agent, and as a result, and that was due to a ruptured brain aneurysm, I should add. And I don't personally think it was anything demonstrably related to the drug, but that means there is a good deal of caution in considering that sort of therapy in anyone who might have a risk or a proclivity to brain hemorrhage. But I think if you were somebody suffering with very severe and refractory migraine, there would be a conversation to have about the relative risks and benefits. The next group of symptoms are the focal neurological deficits, most of which are associated with either seizures or brain hemorrhage. The location of the brain hemorrhage is what will determine whether a focal deficit develops. If you have the bleeding occur in the bit of brain that moves your hand, then it stands to reason that you may not be able to move your hand afterwards if the damage is sufficiently extensive to those nerves. If a seizure triggers a paresis, very often it will be reversible over time. That's sometimes referred to as Todd's paresis. So there's a temporary suspension of the ability of nerves to transmit messages, which is recoverable over a few hours in many cases. So location, as I said, is everything. It's like real estate. Location, location, location. This is an interesting MRI. This is from a 7 Tesla MRI scanner. So this is about as powerful as MRI scans get these days. And this is publicly available images which were made of somebody who died from non-neurological causes. So it's ostensibly a normal brain, although it is shortly after death. And it is in 100 micron slices, very thin slices. So the resolution and the detail provided on this particular MRI is extraordinary. And you can go and have a look at the video of it if you've never seen it. It's really quite something. It took 100 hours in the MRI scanner to acquire those images. And the reason I'm showing it here is because it illustrates very nicely the two types of tissue that exist in the cerebral hemispheres. The outer mantle of grey matter, it contains the nerve cell bodies, and below it you have the white matter. So I don't know what point we lost touch, but this is this remarkable 100 micron thick slice of the human brain and showing the cerebral hemispheres. I started to say that the hemispheric cavernomas are probably the ones with the least likely to be first-time hemorrhages at about 1 in 200 per year. And there's more good news in that those hemorrhages tend to be better tolerated than in other locations. Although the risk of a second hemorrhage once one occurs goes up for a period of about 2 years before returning to that pre-morbid baseline. The risk of a lobar cavernoma bleeding translating into permanent physical disability is relatively low. Of course, it's not trivial, but it's less of an issue than, say, with a brainstem cavernoma. But if seizures are a presenting feature, there is the possibility of a long-term effect on the adjacent brain that makes for future seizures more likely to happen and perhaps more refractory to medical prevention. So those are amongst the people who we suspect might stand to benefit from early treatment of cavernomas in selected cases. The brainstem is this more primitive part of the brain on which the cerebral hemispheres sit. And it's made up of 3 parts. The midbrain is actually hidden inside the hemispheres here. It's called the mesencephalon. And then the next 2 stages are called the hindbrain or rhombencephalon, the pons and the medulla. The medulla, for example, is the center where the points of regulation for breathing, the generation of the heartbeat, all originate. And from the brainstem emerge various nerves that leave through holes at the base of the skull and subserve very vital functions, helping with vision, sensation, hearing, tracking of the eyes, and so forth. But every nerve coming to and going from your cerebral hemispheres pretty much has to pass through the brainstem en route to elsewhere. And this incredible packaging of function in such a relatively small area means that if there is even a small amount of bleeding in that area, it's likely to translate into a problem. And the risk of that happening in the first instance appears to be higher for brainstem cavernomas, about 8% over 5 years from diagnosis in the better quality studies that we have. If they bleed, then the risk of subsequent hemorrhage is of the order of 31% over 5 years, which makes these lesions potentially good candidates for some form of treatment. But the difficulty is, again, because of all the function packed around them, intervention also carries risk of disturbing that function, whether it's surgical or otherwise. There are certain things that seem to increase the likelihood of morbidity from both bleeding and treatment of brainstem cavernomas, including the presence of developmental venous anomalies and cavernomas that transgress the midline, cross the equator, as it were, of the brainstem. The brainstem continues on down through the bony spine. There's a canal at the center of the bony spine, transmitting a tail from the bottom of the brainstem that then gives off nerves left and right through these little orifices on the side of the bony spine, carrying the nervous system throughout the rest of the body, the so-called peripheral nervous system. And that structure is about the thickness of your little finger, with all that function packed in there, as rather similar way to the brainstem. If you are unlucky enough to have a spinal cord cavernoma, you're in a relatively select club. They're the least common cavernoma we see, And until recently, the case reports in the medical literature were below 1,000 cases. They have been known about since the early part of the 20th century. With so few cases to refer to, it's difficult to make estimations about the risk they pose. And as a result, it's difficult to advise folks who trip across them when they are asymptomatic or even minimally symptomatic. But the consensus at the moment is the risk of hemorrhage sits somewhere between 2.5% and 8% per annum. Some authorities would argue it's up to 10%. But one would need to acknowledge that the risk of intervention is also important. This is a similar diagram showing the various groups of nerves packed within the spinal cord. The red groups are traveling down from the brain to tell organs what to do. The blue groups are carrying information about what organs are doing and what they need to the brain. And we have to find a way between those structures to enter the spinal cord if we are going to physically remove a malformation. Usually, the safest areas to do that are between the groups at the back, which help coordinate movement and make it smooth, or in certain areas of the spinal cord close to sensory nerves, reasoning that an area of numbness will be more tolerable to a person than loss of movement in the right circumstances. So this is an example of a cavernoma in the spinal cord. You can see the dark blush at the back. And when those nerves are separated, it begins to peak out and it gets withdrawn, and then the cord itself is repaired. Those sutures are about the thickness of a human hair. The conclusion of the consensus view at the moment is that if they're symptomatic, intervention of some sort is usually justified, but it's a very nuanced conversation with your therapist. And as with any cavernoma, it comes down to balancing the results and impact of surgery against what the risk is perceived of the disease for the individual. And there are a lot of things that feed into that. So who's the right person to be making the decision?
Morning, gentlemen. Good morning, sir. Oh, sir.
Now, you just lie still, old fellow. I'm just going to discuss your case with these young doctors here. Take your pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look. Have you looked?
Yes, sir.
See anything?
No, sir.
Very good, carry on.
Gently, man, gently. You're not making bread.
Don't forget, to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. Found it?
Yes, sir.
Well, what is it?
A lump.
Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk.
So the only person without a line in that scene was the patient. And thankfully, we've moved on in our attitudes. I'm very fond of this approach called shared decision making when it comes to making complex decisions about treatment. We talk sometimes about a 3-talk model, where the first meeting with your potential neurosurgeon, for example, is to describe what the problem is and provide you with options, and then come back at a separate occasion, having allowed you some time to reflect and learn about the condition, to talk about the ways forward before finally meeting a third time to make a decision. And you can have more meetings as needs be, but the key thing is to allow time, which is often at a premium. So when going to your consultations, it's sometimes useful to have something of a framework about what you want to take away from the conversation. And this BRAN framework, I think, is quite useful. You ask, what are the benefits? What are the risks? What are the alternatives, however unlikely? And what happens if I do nothing? So that's often a useful little mnemonic just to file away, because you may be coming to that consultation with carrying really quite a significant burden, even if it is that you've been diagnosed with a lesion that has potential to harm you or harm you more in the future or someone you care about, but that potential has not been realized yet, and maybe it will never be realized. So how does one live with a condition like that? And there are important roles for, as well as your clinical team, peer support such as we're engaged with today, and your own self-empowerment by learning about the condition and what's available, and also what is not known. As more therapeutic options emerge, that doesn't always translate into easier decision making, because very often the impact of treatments are not as great as are hoped. The consequences are maybe not understood in the early phase. So it can sometimes be a mixed blessing. And with that, I am going to wind up my talk. I hope I'm still on. And thank you for all the volunteers for everything you do for the patients I look after or help to look after as well. We all really appreciate it.